The first wave of the COVID-19 pandemic cleared out emergency rooms. Between March and June of 2020, hospitals across Alberta, Canada, recorded a 34% drop in emergency department visits, along with a 15% drop in hospital admissions compared to the previous year. At the time, medical professionals pointed to two logical explanations. Lockdowns kept people home, resulting in fewer car accidents and sports injuries, and those who were sick simply stayed away, avoiding hospitals out of a fear of catching the virus in the waiting room. That top-line drop is statistically accurate, but it hides a much darker reality. When researchers looked past the provincial averages, they found that this massive reduction in hospital traffic wasn't uniform. The overall decline acted as a statistical illusion, concealing profound disparities in who was actually getting care. To see what was actually happening inside these hospitals, researchers used multivariable linear regression. Multivariable linear regression is a statistical method that controls for multiple variables at once to pinpoint exactly how specific factors influence an outcome. They applied this method to intersectional demographic data. Instead of looking at one monolithic average patient, intersectional data breaks the population down by multiple overlapping identities, separating the numbers by age, sex, geography, and First Nation status. Splitting the data revealed two opposing crises occurring at the exact same time. The first was a wave of missed care. Specific vulnerable groups were experiencing severe, life-threatening emergencies, but were actively avoiding the hospital. The second was systemic funneling. Other marginalized demographics completely lost access to their primary care clinics and were forced to rely on the emergency room even more heavily than before. Declining patient volumes during a crisis often mask persistent medical need. In 2020, the drop in volume meant that the health system's friction was being absorbed by the most vulnerable patients. The patients who crossed the sliding glass doors of the ER in the spring of 2020 looked very different than they had a year prior. The median age shifted older, rising from 37 to 41. This chart shows the shift in the Canadian Triage Acuity Scale, or CTAS, used by nurses to evaluate patient conditions, ranging from level 1, immediate resuscitation, down to level 5, non-urgent. Between 2019 and 2020, patient volume visibly shifted out of the low acuity brackets and concentrated heavily in the high acuity levels 1 through 3. As a direct result, the proportion of ER visits that ended in a hospital admission jumped from 8.3% to nearly 11%, and the number of people who grew tired of waiting and left before being seen dropped by almost half. The data clearly shows that people with minor ailments or avoidable emergencies successfully managed their conditions at home. But this raises a vital question. Did the pandemic exclusively filter out the people who didn't truly need emergency care? Or did it also filter out patients experiencing unavoidable, critical emergencies? The emergency department was operating at a severely elevated severity threshold. To understand the true cost of the lockdown, we have to isolate exactly who failed to cross that threshold when their life depended on it. Researchers conducted a sub-analysis, specifically looking at life-threatening diagnoses. These are conditions like severe cardiac events, kidney failure, and sepsis, internal biological emergencies that are completely unaffected by public health measures like masking or staying off the roads. Overall, emergency room visits for these specific conditions fell by 15%. Presentations for cardiac conditions dropped by 20%, and cases of sepsis dropped by 14%. The biological incidence of heart attacks and systemic infections does not simply pause for a viral pandemic. So, which demographic groups stopped going to the hospital while experiencing these life-threatening events? The multivariable models revealed that seniors experienced statistically larger reductions in visits for these critical categories compared to younger adults. This chart shows the adjusted average drop per facility for these life-threatening conditions. When compared against the baseline of adult men, women and other sex patients saw an even sharper decline, registering a drop of 4.02 visits per facility compared to a drop of 3.90 for seniors. The clinical reality? People were still having heart attacks. They were still developing severe infections. But instead of calling an ambulance, these specific patients stayed home. For seniors, this avoidance likely stemmed from a highly acute fear of hospital-acquired COVID-19. They perceived the ER as a high-risk environment and chose to wait out severe symptoms. For women, the data suggests a disproportionate absorption of pandemic-related systemic burdens. With the sudden closure of schools and the shift in day-to-day caregiving responsibilities, women were more likely to delay their own critical care to manage the immediate needs of families. These missing emergencies document a severe crisis of missed care. Behavioral avoidance, driven by a combination of fear and systemic societal inequality, actively suppressed the delivery of life-saving acute care. The data reveals an entirely different, counterintuitive crisis when we examine the utilization data for Alberta's First Nations populations. This chart shows the percentage decrease in emergency department visits across multiple population categories. Every group shows a decline, pointing downwards into the negative. However, the blue bars representing First Nations patients are consistently shorter than the red bars representing the non-First Nations baseline. This chart shows changes in hospitalizations. Most groups are deeply negative, but on the left, urban First Nations adults spike into positive percentages. Models confirm this anomaly. The baseline population saw 7.7 fewer admissions per facility, but First Nations saw a drop of only 3.28. Lockdowns and travel restrictions were universally applied. Many First Nations communities enacted their own strict protocols. So why did this specific marginalized group see a spike in emergency hospitalizations? When researchers reviewed these findings with First Nations elders and health professionals, the interpretation was clear. These patients faced a complete lack of alternative, accessible care. During the lockdowns, the baseline population largely replaced in-person primary care with virtual visits and telehealth consultations, which kept them out of the hospital. But structural inequities, a lack of culturally safe primary care options, and the digital divide meant First Nations populations were largely cut off from this virtual safety net. This empirical data dismantles the biased stereotype that marginalized groups somehow misuse the emergency room. Instead, it proves that when primary care infrastructure systematically fails, the emergency department functions as the absolute last and sometimes only accessible node of care. The top-line 34% drop in emergency visits in 2020 contains two entirely opposing realities. On one side, the disruption of the pandemic induced a dangerous avoidance of life-saving care, particularly among seniors and women. On the other side, the sudden removal of primary care alternatives forced structurally marginalized groups to bypass preventative care entirely and rely on emergency hospitalizations. Relying solely on aggregate volume data, like celebrating a broad reduction in hospital traffic, is a critical administrative failure. It creates a blind spot that actively conceals life-threatening inequities. Today, emergency departments face a crisis of critical staff shortages, closed hospital beds, and rebounding patient volumes. Managing this ongoing strain requires administrators to abandon simplified metrics. Health systems must adopt equity-oriented intersectional data tracking as a baseline standard for operational oversight. Hospitals need continuous, real-time visualization of absolute and relative changes across specific demographics to identify these hidden crises as they emerge. Systemic resilience fails if administrators only count how many people are sitting in the waiting room. They must possess the tools to track who is disappearing from the system and understand why.